Welcome to NCSS Here for You. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. We take our role in the community seriously and strive to provide the highest quality services. According to Eric Erickson, a noted developmental psychologist, every person must pass through a series of 8 interrelated stages over the entire life cycle. NCSS provides a continuum of services to meet the needs of individuals who at any point seek assistance. NCSS's purpose is creating a stronger community, one person at a time. Now, let's get to today's show.
I'm Joe Halco, Director of Community Relations for Northwestern Counseling and Support Services, and welcome to another episode of NCSS Here for You. Each month on this program, we discuss a human services topic, and we do that with staff from one of our 3 service divisions. Our 3 service divisions are Behavioral Health Services, Children, Youth, and Family Services, and Developmental Services. And, on occasion, we have guests from organizations that NCSS collaborates with throughout the year. This month's episode is titled, Medications, Not a Cure-All for Mental Illness. There are many people that believe that if they're struggling with a mental illness, that all that's required to treat the symptoms are medications. Although medications can be effective as part of an overall treatment plan, which includes individual or group therapy, there are many factors that are considered when addressing the wide range of mental health conditions. There have been instances when doctors see patients that are on numerous medications but continue to report no progress in recovery. In addition, addiction can also take its toll on certain individuals that become reliant on the very medications that are intended to improve their lives. To discuss medications and mental illness in greater detail, I'm pleased to introduce this month's guest, Dr. Steve Sobel, NCSS Medical Director. Dr. Sobel, I want to welcome you to the program.
Thanks.
Well, let's start with, so a patient sits down and says, I have a chemical imbalance. All I want is meds to feel better. What's wrong with this picture?
Well, basically it's not that simple. We can't really reduce a person and their suffering to a few chemical reactions gone astray. So usually there's not really just some magical pill that will take care of this, and there's not really a quick fix. It's not unusual that a medication alone would be adequate. And this idea that we have specific treatments for specific chemical imbalances that we know about is a bit of a myth, really. So we have to look at, is it a diagnosis that might be treatable with medications, and would therapy be more effective or more appropriate? Is there a medical problem that might be contributing to some of the symptoms, or substance abuse going on? And again, not all distress can really be treated by medication. So if it's trauma related, for example, that might be better addressed through therapy, or sometimes what's called mood swings is more of a characterological problem that would be addressed through therapy. And we have to look at the whole context. Like, there might be a lot of stressful things going on, there might be unemployment, financial issues, relationship issues, legal issues, abuse, and so on. So and at a full comprehensive mental health agency, we can try to help with a lot of those issues as well. So if we just focus entirely on medication solutions, that may actually delay response, because we'd be barking up the wrong tree, basically.
And basically with what you're saying that I think is so critical here is, a person may see an ad on television and think, oh my goodness, that's going to be the answer for me. But every situation is different, as you've suggested already, and therefore how you're going to approach it and what the results can be will also be different. And in many instances, medication may be the last thing somebody needs.
Right.
So could you say more about the shortcomings of chemical imbalance theory?
Well, it's definitely a goal in psychiatry to have understanding of the underlying neurobiology of the major illnesses. And we've made a lot of progress. It's hard to say what's more impressive, how much we've learned about it or how much we still don't know. But we're still not there yet, so it's a bit misleading to claim that we are. We just don't really have a full understanding of what that chemical imbalance might be, even after decades of research. We know it's not as simple as too much dopamine in schizophrenia or not enough serotonin in depression, for example. Even though the medications, for example, antidepressants or some antidepressants might work through serotonin, and antipsychotics work at least partially through dopamine, we can't just reason backwards and say, therefore, that's the underlying cause of the illness. In fact, apart from the mechanism of action of these medications, we don't really have much definitive evidence of what that imbalance might be. And even the mechanism of action of the medications isn't entirely clear. But it gets complicated. For example, there's not just one serotonin receptor, but there's many types, and some of them have opposing actions. And in recent years, interest has actually shifted to a different neurotransmitter, glutamate. So there's a lot that's not known about the specific imbalance. And one of the things that impedes progress is that our whole diagnostic system doesn't really carve nature at its joints, so to speak, in the sense of describing distinct biological entities. Even the head of the National Institute of Mental Health has criticized the DSM-5, which is a diagnostic manual, as doing a disservice to our patients because it doesn't promote a neurobiological understanding. So we're left with diagnoses like depression or schizophrenia or bipolar that are actually a collection of multiple diseases with multiple causes. And it's sort of analogous to fever. We wouldn't say somebody is diagnosed with fever. We would say they have a fever and now we want to find out what's the underlying illness. So we may have non-specific treatment like an aspirin that would help with the fever, but what we really want is to target the underlying disorder. So there's more research that needs to be done. And the medications we do have are relatively non-specific. They do have effects on the brain. They can be very effective, even life-saving, but for some people, but for others they may have only partial benefit or no benefit. So they're still rather blunt instruments at this point.
Now, is it true that in many instances medications don't have any impact on individuals, such as those that might be struggling with mild depression?
Yes. I mean, first of all, again, there's not really a medication treatment for all forms of distress, but if we're talking about illnesses where they might be indicated, like you just mentioned, mild depression, they may not necessarily be needed. Medication is probably no more effective than placebo for mild depression, although we have to remember placebo is actually fairly effective, and what that tells us is the mind or what we're thinking or believing can have effects on the brain. And that's actually been shown. For example, cognitive behavioral therapy for OCD has effects on brain circuits that you can actually demonstrate with brain imaging. And also medications are sometimes used off-label. So like if it's approved, say there's a mood stabilizer approved for bipolar disorder, but then it might be used for just moodiness or anger control. So once they're on the market, they can be used for anything. But in that situation, it's likely that the side effects would outweigh any minimal benefit. In another situation, we see as medications being used more for behavioral control than for treating a specific illness. So, for example, children with out-of-control behavior, or people with intellectual disabilities who might be frustrated about something, or adults with dementia and agitation. So, I mean, there are a lot safer ways to treat, for example, agitation in dementia. If it's in the nursing home, maybe they need a change in roommate, for example, or instead of a shot of Haldol. So you want to look at, what's disturbing the person, what's getting them upset. And apart from antipsychotics are the medication that's used most often, but they've actually been shown to have almost no benefit and to double the mortality risk. So other options like just one-to-one attention, music therapy, pet therapy, addressing pain issues or other medication issues, changes in routine are ideas that are all more effective and safer in that kind of situation. So,
Now, and this always fascinates me, but with the enormous number of television, print, and electronic advertisements for antidepressants, anti-anxiety, mood-stabilizing medications, hasn't the pendulum swung too far, resulting in many patients believing that the pill is the sole answer to all of their concerns?
Yeah, I would agree. The pendulum has swung too far, and there's really a need for more healthy skepticism because we're really facing kind of an epidemic of overdiagnosis and overmedication and pathologizing of normal behavior. And so the medications can be extremely helpful, but they are overutilized. And I think pharmaceutical companies put a lot of effort into making sure they'll be overutilized. I think I've seen figures that they've spent about $25 billion a year promoting medications to physicians and another $3 billion in the direct-to-consumer advertisements. The leaders in our field, many of the experts in the field have a lot of conflicts of interest. They receive drug company money for speaking, speaker fees, consultations, or for research. And a prominent example that made the New York Times actually was Professor Biederman from Harvard, who's done more than anybody to promote the idea of pediatric bipolar disorder and the need to treat that with drugs. He received over $1.5 million in pharmaceutical money. So that's a real conflict of interest. It's one way that the use medications is expanded by having experts weigh in that way. There's also other more like subtle efforts. For example, if we have bipolar disorder and medications for that, then we get expansion of that indication by people talking about bipolar spectrum disorder. So it might be people who are just moody or have anger control problems. And then we get expansion to pediatric usage, so that might not be researched. Maintenance treatment is recommended often for a lifetime, even though most of the studies are done for like 6-8 weeks, maybe 12 weeks. So you might ask, based on what? And then early intervention is also promoted, the idea being to intervene before the full illness is expressed, which sounds good, but there's a lot of problems. One is that a lot of people who are identified as being at high risk will never actually develop the illness, so you'd be doing quite a bit of harm by giving everybody medication. But the early intervention wouldn't necessarily have to be medication. I think that that kind of overuse of biological medications isn't unique to psychiatry. I mean, physicians will use the tools they have, and unfortunately, if the only tool you have is a hammer, then everything looks like a nail, and that does tend to happen, so it has to be kind of reined in at times. But we've seen back surgeries being overperformed, antibiotics being overused, and now we have treatment-resistant infections. It was just in the paper a couple of weeks ago about breast ductal carcinoma in situ might not need to be treated with mastectomies. But maybe a remarkable illustration is like people who go on hospice care tend to actually live longer than people who opt for aggressive medical treatment. So really, I think it shows that too much of even a good thing can become a bad thing. Is what we run into.
Now, what would the appropriate use of medication look like?
Well, again, we're focusing on the limitations, but I don't want to lose sight of the fact that they can be very effective when used appropriately. So, if the illness is severe, the consequences are severe, let's say it's causing a lot of suffering, or the illness is resulting in behavior that threatens the individual's safety or other people's safety, and it's an illness that can be treated with medication, then that certainly could be appropriate. If you do start medication, you want to make sure it's actually working, because just because it's indicated doesn't always mean it's going to work, and if it's not, it should probably be stopped. And even if it is working, you want to make sure that the benefits are greater than the side effects, and you're using the minimal number of medications and the minimal dose, and considering whether you can maybe discontinue the medication at some point after a period of time. And you want to make sure you're using it in combination. You don't want to be using the medications in place of therapy or in place of making necessary life changes or in place of addressing substance use or as a means of escape from problems or for ongoing behavioral control, for example.
Now, do you find that there's a general lack of understanding of potential long-term side effects of medications and an overestimation of what the benefits of the meds are?
Yeah, I would say that we all need to kind of acknowledge there's a lot we don't know about especially the long-term effects. And even when we look at effectiveness, if you actually look at the studies, it's often not as impressive as you might think. For example, if you look at antidepressants, a favorable study will show that 2/3 of people respond to an antidepressant, but a third respond to placebo. And response isn't necessarily a full recovery. It's usually measured as a 50% reduction in a rating scale, but you could still be depressed. If you look at actual remission, which would be more like a cure, then that might be closer to 35%. So they're definitely not magic pills, but they can be effective. But also, like even the more powerful medications like antipsychotic medications, which we do know of a lot of side effects. They can cause weight gain, they can increase the risk of diabetes, raise cholesterol, increase the risk of heart disease, they can cause involuntary neurological movements, something called tardive dyskinesia. They can affect cognition, and now we know they can cause cerebral atrophy, which is actual shrinkage of the brain. Even medications like that are sometimes used for things like anxiety or insomnia, which they're not really even indicated for or studied for. And maybe even more disturbing is that even when they are indicated, like for schizophrenia, there is some evidence from the few long-term studies that are out there that people may do better if they never use the medication or if they are able to get off of the medication. When you look 3, 5, 10, 20 years later, not when you look in the first year or two, then there's definitely a better response to medication. But of course, not everybody can get off the medication or get by the initial psychosis without that. So it's not a one-size-fits-all by any means. But we do need to have more research on long-term effects and side effects. Another example would be the risk of dependence or addiction, for example, with anxiety medications, like in the Valium family, Klonopin, Xanax. Sleep medications can also cause dependence. Stimulants that are used for ADHD can be abused. And with regard to the anxiety medications and sleep meds, they've actually been shown to triple the mortality rate, which is pretty remarkable. And there's some evidence that they may increase the risk of irreversible dementia, which that's not a firm finding, but just an additional reason to think twice about using them long term. And sleep meds are another example as far as how effective are they. Like studies that find them effective sometimes show that the medication adds on average 15 minutes of sleep compared to the placebo. So you would have to question, is that really worth the risk of being groggy the next day or impaired and so on and so forth. And then there's also concern about medications that aren't considered to be addicting, like antidepressants, but might they cause some long-term changes in the brain that then make people unable to come off the medications because of the changes induced by the medication. And that could lead to a self-fulfilling prophecy where the doctor might stop the medication, see the person gets worse, and then start it and see they get better and conclude that they need the medication. But what we need to be sure that's not like akin to an alcoholic who's drinking a 12-pack, and if they stop the 12-pack, they would look a lot worse, and they might look worse for many months, but we wouldn't advise them to get back on the 12-pack. So there's just a need for more caution and more knowledge, and the golden rule in medicine is really, first of all, do no harm. But we do see some strange things going on, like people on 6 or 7 medications or more, still complaining about the same distress that led them to initially start medication. So that kind of thing, nobody knows what that kind of chemical soup does. That's just not researched at all. And so we're left sometimes relying on expert opinion or consensus rather than clear research. And we can't be too complacent about that because, for example, in the past, expert consensus would have told us that lobotomies were a wonderful treatment. The developer of that won the Nobel Prize in Medicine in 1949. Mm-hmm. Another example would be insulin coma therapy. For example, John Nash, who was depicted in A Beautiful Mind, mm-hmm. received insulin coma therapy at McLean, which was one of the top mental health hospitals in the country. This was in the 1960s. And those are the kind of things we try to assure ourselves we wouldn't do, but we need to maintain this skepticism. And actually, John Nash is an example of somebody who decided to refuse all treatment, all biological treatment, and did go on to recovery, at mm-hmm. least well enough to win the Nobel Prize in economics.
Which is quite an achievement.
Yeah, fair degree of recovery. Yeah.
Now, doctor, some individuals seem to become over-reliant on medication solutions, as we've talked, without focusing on other changes or approaches such as therapy. Why is this the case, and what can be done about it?
Well, it can be tempting to rely on medications. First of all, it's a relatively effortless treatment, and if there's a hope for a quick fix, then there can be that. And some illnesses may be mainly biological, but certainly not in all cases. So I think it's really the prescriber's primary responsibility to determine if it's a illness that would be treated appropriately with medication, or if therapy might be a better option, and to make sure that the medications aren't being used as an escape, for example, which would be more like what substances are used for, as opposed to medication should be helping to improve functioning or engage in life. So you want to make sure it's being used for that purpose and actually leading to improvement, and not being over, doses and too high in that minimal number of medications. But it is a difficult pattern to stop because the major pharmaceutical companies do spend billions of dollars trying to continue that pattern. And the other thing we see is insurance companies. A lot of what is practiced in medicine depends on what they decide to reimburse. Mm-hmm. And right now they really favor medication treatment. So changes in that regard could promote other approaches. I mean, it doesn't seem right that it should be affected so much by insurance policies, but in reality it can be. So that's
it certainly has a big effect on
another thing that could change that kind of thing.
Now, we've discussed the importance of the treatment plan, including individual or group therapy for individuals who are struggling with a mental illness. Don't most people, though, believe that receiving treatment means seeing a psychiatrist? That they jump right from when they hear the word treatment or therapy, that means they have to go to a psychiatrist?
I don't know if it's most people. I guess some people may assume that they're going to need medication, or hope that there would be a quick fix for the problem. But as far as therapy, that can be provided by clinicians with quite a range of clinical training. Can be psychiatry, psychologists, social workers, mental health counselors. If medication's involved, then it has to be a physician. It could be primary care doctor or psychiatrist, or somebody else with prescribing authority, like nurse practitioners or physician assistant. So any of those could be involved in treatment.
Now, before we go, you've written a book, and which we have here, and it's a fictional account of how certain psychiatric disorders affect not only the individual, but their loved ones. What prompted you to undertake this project?
Well, I enjoy writing, for one thing, and one of the purposes of the book was to, through these fictional accounts that do ring true to my experience, to hopefully shed some light on the experience of mental illness and the impact on the individual and on the family and so on, and hopefully increase empathy and understanding of the illness, but through examples rather than just presenting dry facts.
Sure.
And then each vignette or story was followed by a follow-up section to try to provide kind of a longer-term perspective and generally some sense of hope as far as ultimate outcome for these illnesses.
Well, I will tell you, in reading it, and I'm not a clinician, as you know, I found it fascinating, and what I really liked about it is that with each one of these different vignettes, you were touching on different types of disorders, and you could really get inside the effect it had not only on the individual themselves, but on the loved ones and those around them, and I found it fascinating, fascinating read, actually.
Thanks.
Now, over the past several years, NCSS has been involved in numerous initiatives that are related to integrated healthcare and that model. And this is a step in, of course, serving the whole person. Do you feel that over time this will have an impact on improving outcomes for individuals that are struggling with mental illness?
I do. I mean, I think that it helps to kind of correct this error of the mind-body dualism. So we know now that the mind and the brain are one and the same, really, and but it's this separation has led to separate sites for treatment of mental health care and physical health care. So that is being addressed through this more integrated kind of care, and it also helps correct, hopefully, one aspect of stigma, which is not sometimes lack of access to quality health care. So, for example, we know that it's been shown that people with major mental illness who present to an emergency department with a heart attack are only about 40% as likely to be referred for cardiac catheterization, which would be indicated. And people with schizophrenia have a lifespan that on average is about 15 to 20 years shorter than the general population. And there's a lot of reasons for that. Sedentary lifestyle could be a problem, higher smoking rates, medications that we give also can contribute to that. But one factor that we can do something about is access to health care. So, and they also tend not to get as much preventive care. So by having a primary care provider on site at NCSS, for example, we can improve that access. And on the flip side, most people actually present to the primary care provider for treatment. That's the usual point of entry. So we're also able to place counselors there who can help in many ways, including, first of all, the primary care doctor might not feel comfortable treating major mental illness. They feel it's outside their scope of practice, or they're not set up to handle that. So the counselor on site can help with recognition and triaging and screening and appropriate referrals and collaboration, communicating with psychiatry, and also making sure people don't fall through the cracks and drop out of treatment. So I think both having primary care on site in our setting and having mental health counselors in the primary care setting can improve outcome.
Well, excuse me, one of the things that I'm excited about that model is, when we always talk about how many people that get referred from primary care providers, say to NCSS, that don't really take the step. They're referred, it's all being done in a way that hopefully they're going to receive the next level of treatment, but they make the determination that they're not going to make the call, they're not going to walk in the building, whatever the case may be. So therefore you have such a large number of individuals who may not even begin to get treatment for maybe 5 or 10 years after they have presented initially with, say, depression or anxiety or what have you. And in having this model, as you've said, I think it helps to, number one, shrink the time frame, and number two, hopefully reduce some of the stigma that's involved with, the minute you say the words mental health or mental illness, a lot of people flee. For some reason, they think because it's brain-based that it's something that it is, just very different from talking about the heart or the liver or what have you.
Right. Yeah, it definitely makes a huge difference to have somebody right in the same building who, you can just walk down the hall and see them. We've seen something similar with lab tests, for example, when we now our nurses can draw the labs, but before that, when they had to walk across the parking lot to the hospital to get the labs done, the compliance rate was much, much lower. So having somebody actually on site makes quite a huge difference.
Indeed. Well, it's hard to believe, but our time is up for this month, Doctor, and I certainly want to thank Dr. Sobel for being on the show today and sharing his insights on medications, the potential of misuse, and their appropriate use in addressing mental illness. I also want to thank you, the viewer, for spending time again with us this month. You can learn more about NCSS and all of our programs and services by logging on to ncssinc.org. I'm Joe Halco, and I'll be back next month with another episode of NCSS Here for You.
This has been another episode of NCSS Here for You. We hope that you found today's discussion informative and educational. Since 1958, Northwestern Counseling and Support Services has been providing access to high-quality services which promote healthy living and emotional well-being to the residents of Franklin and Grand Isle counties. Over the years, as the needs of the community have changed, so too have the programs and services that we make available to assist children, adolescents, adults, families, and seniors. Thanks once again for tuning in this month. NCSS's purpose remains creating a stronger community, one person at a time.